Good evening, everyone. Welcome to Meto Clinic. So it's monsoon here and it's raining very heavily here. I just had my hot cup of coffee and I'm recording this video. So welcome to this video, and in this we will discuss about vitamin B12 and magnesium deficiency. There are three important micronutrients that are important. Micronutrient deficiencies that are important in diabetes mellitus. One was vitamin D that we discussed in the previous video. In this video, we'll discuss about vitamin B12 and magnesium. Let's get started. Now, vitamin B12 deficiency is important in both type 1 and it's important in type 2 as well. Now, if a patient with type 1 diabetes mellitus has vitamin B12 deficiency, then you should always think in terms of pernicious anemia. Pernicious anemia is very common in people with type 1 diabetes mellitus, so you'll have to get them tested for anti-intrinsic factor antibody and antiparietal cell antibodies. Now, if a patient with type 2 diabetes mellitus has B12 deficiency, it can be due to multiple reasons. One reason is chronic metformin therapy. Metformin, when you give it for a longer time, can cause two important side effects. So one is B12 deficiency. Another is, in some people, it can cause lactic acidosis. Then one more reason where diabetic patients can have B12 deficiency is when they are vegetarians. These are the two important things. When do you screen for vitamin B12 deficiency? If you are giving patient metformin and the patient is on chronic metformin therapy, you will actually check B12 deficiency annually. But if a patient is coming to you with frank symptoms of megaloblastic anemia or symptoms of neuropathy, the patient is saying that, I am having tingling sensation in hands and feet, then you will screen for B12 deficiency immediately. Is this clear? If the patient is asymptomatic on metformin therapy, annually you will check. Otherwise, if the patient is symptomatic, immediately get vitamin B12 levels done. Now, vitamin B12 actually costs around 1000 to 1500 rupees. And annually, what all you'll perform complete blood count, fasting lipid profile. If the patient is antihypertensive, you'll also ask for serum electrolytes, urine albumin by creatinine ratio, right? Along with that, if you're adding vitamin B12, this will act as a financial burden to the patient. So you should always understand what is the paying ability of the patient. If the patient can afford B12 testing, the patient can afford, or the patient will not be able to afford B12 testing. If the patient can afford B12 testing, then you get both of the things done. You get complete hemogram done and B12 assay done. If the serum vitamin B12 levels are less than 200, then it's a frank deficiency. You will give cobalamin and folate injection. Always remember, even though there is B12 deficiency, you should always give cobalamin and folate. The reason is, cobalamin and folate, they are dependent on each other, and if you treat one deficiency without treating another deficiency, there won't be any response in the treatment, improvements in the treatment. And folate, right, if you have to screen for folate deficiency, it's very costly. Rather than that, you just treat the patient with folate. Less than 200, immediately start with cobalamin injections and folate supplements. Now, if it's between 200 and 300, it means borderline, okay? You cannot say it's deficiency, you cannot say it's adequate. For that, see if the patient has any symptoms. Is the patient symptomatic? Or complete hemogram, is it showing anything like is there anemia or macrocytes? In such cases, you will again start with cobalamin and folate injections. Now, if the patient has B12 levels between 200 to 300 picogram per ml and the patient is asymptomatic, now how do you actually see if there is vitamin B12 deficiency or not? In such cases, check for methylmalonic acid levels. Whenever you are in doubt, you can get two things tested. Like you can confirm it with two things: methylmalonic acid and serum homocysteine levels. Both of these are raised in vitamin B12 deficiency. However, I personally choose methylmalonic acid over homocysteine because methylmalonic acid is very specific, whereas homocysteine can increase in folate deficiency, B12 deficiency and pyridoxine deficiency. Homocysteine is non-specific, methylmalonic acid is very specific. If you get both of this done, it will be very costly to the patient. So choose one, choose methylmalonic acid. Now, if methylmalonic acid levels are elevated, then it's B12 deficiency. Again, give cobalamin and folate injections. This is the first scenario where patient can afford vitamin B12 testing. In the second scenario, patient cannot afford B12 testing. In this case, get only hemogram done and treat the patient if there are any features of megaloblastic anemia or like macrocytes, elevated MCV. In such cases, you will be treating the patient with vitamin B12 injections and folate supplements. Now, what is the difference between patient can afford B12 testing and patient cannot afford B12 testing? In the first case, you will be treating the patient even if the patient does not have any symptoms. Whereas here you will have to wait until the patient has some symptoms and then treat. Okay. Here you can, in the first scenario, you can treat the patient early. Here you will be treating the patient in the later course of disease. What do you give? If I say one injection of B12 or one tablet of B12 or one dose, it will always be 1000 microgram of cobalamin. Now cobalamin can be two. It can be in the form of hydroxocobalamin or it can be in the form of methylcobalamin. In the market, the common thing that you find is methylcobalamin. Oral versus IM, which is better? IM is always better. Reason, if you give absorption through oral route is just 1 to 4%. Meaning, normally they come in the capsules of 1500 microgram. Okay. Only 1% of this is absorbed. Means 15 microgram will be absorbed. If you give 1500 microgram of vitamin B12, only 15 microgram will be absorbed. One more thing is that there will be damage to mucosa. Whenever there is B12 deficiency, there will be damage to mucosa as well. That will further impair the absorption of vitamin B12. That is why oral route is not preferred. IM, the absorption, if you give 1000 microgram of cobalamin, how much is absorbed? 10% is absorbed. Means around 100 microgram is absorbed. See, here only 15 was absorbed, here 100 microgram is absorbed, so IM is always better. The second reason is the cost. Okay, each capsule or each tablet of vitamin B12 will cost around 20 rupees. So patient has to spend 20 rupees every day. If you are giving patient oral tablets, it should be given every day. IM injections, I will tell you the protocols. So 20 rupees per day will be the cost for the patient. But injections will not be like that. You will be giving either weekly or either on alternate day or monthly. Cost is more in oral compared to IM. That is why IM is always better. You should always consult patients for IM B12 injections. Only when they are very adamant you can use oral. Is this clear? Protocols. There are two important protocols. One is mainly followed in UK, another is mainly followed in US. This one, first one is UK. Here, this is also the protocol that is said in Harrison as well. The latest edition of Harrison says this protocol. You will be giving 6 IM injections of 3 to 7 days apart. After that, you will shift the patient to monthly dose. It's either once in a month or once in 3 months. Okay, it depends on the patient to patient. If they are very symptomatic, some patients, what happen, once you stop B12 injections, they become symptomatic very early, maybe within 1 month, 2 months. In such patients, you will have to give monthly injections. Whereas some people become symptomatic after maybe 2 months, 3 months. In those patients, you can shift to once in 3-month injections. So UK is first 6 doses will be given 3 to 7 days apart. After that, you will shift the patient to once in a month or once in 3 months, 1 to 3 months, 1 dose in 1 to 3 months. Second is, this is followed in US. 1 IM injection every alternate day. So for first 1 to 2 weeks, you will give every alternate day vitamin B12 injection. So when I say vitamin B12 injection, it is 1000 microgram of methylcobalamin or hydroxycobalamin. In India, it's most commonly methylcobalamin. 1 IM injection on alternate day for first 1 to 2 weeks. Then you will shift the patient to 1 injection every week for next 4 months. It will become 4 weeks, like 1 injection per week for next 4 weeks. After that, you will shift 1 injection per month indefinitely. So first it was alternate day, then 1 injection per week, then 1 injection per month. Okay. What do you educate the patient? Patients, B12 is present mainly in meat. That is why vitamin B12 deficiency is seen in vegetarians, meat, green leafy vegetables, milk and milk products. If the patient is vegetarian, so what happens? These green leafy vegetables are there, right? On that there are bacteria which can actually produce vitamin B12. Now what happens when we buy any green leafy vegetables? We actually wash it, like overwash it. Most of the times the green leafies are very muddy, so we overwash it or we overcook it. During this process, the bacteria is lost. That is why you should counsel the patient that if the patient is vegetarian, you should not overwash and overcook green leafy vegetables. Okay, that is how they can get some source of vitamin B12. Avoid overfrying and overcooking. Second important thing is magnesium and diabetes. The normal magnesium levels are 1.7 to 2.5 milligram per deciliter. Several studies have shown that magnesium deficiencies actually increases insulin resistance. Now, what is the actual dose? What is the exact dose that can prevent insulin resistance? This is not very clear until now. There are several studies conducted which used doses between 250 to 400 mg per day for 3 to 4 months. And it showed that it improved insulin sensitivity, blood pressure and lipid profile. You can give any dose between 250 to 400 mg per day for 3 to 4 months in order to tackle insulin resistance in diabetes mellitus. Let's come to the interesting part, the case study. Now for quick recap or quick revision, we'll solve a case. A 65-year-old patient with type 2 diabetes on chronic metformin therapy complains of tingling sensation of hands and feet. What are the clinches here? The patient has type 2 diabetes. The patient is on chronic metformin therapy complaining of tingling sensation of hands and feet. What can be the differentials for this? So the first differential is always what? Don't think of B12 deficiency. It can be diabetic neuropathy. The patient has diabetes and then tingling sensation. So it can be diabetic neuropathy. What is this type of diabetic neuropathy called? DSPN, distal symmetric polyneuropathy. Then second can be vitamin B12 deficiency. What can be third cause? Can be calcium also. Calcium deficiency. Now these are the differentials that we have in mind. Let's see the lab investigations. What is the lab investigation showing? Hemoglobin is 10 gram per deciliter. So the patient has what? Anemia. Now let's see MCV. MCV, is it normal or high or low? It's high. Normal you can take somewhere around 86 to 92 is normal. So it's more than that, it's high, 1 or 2. So there is macrocytic anemia. Previously what? The patient had tingling sensation. There is neuropathy and there is macrocytic anemia. So this is pointing towards B12 deficiency. Other parameters are normal. HbA1c 7. So if the HbA1c is 7, the chances of neuropathy might be slightly low. Serum calcium is also normal. The normal level is between 9 to 11 milligram per deciliter. So now we have that, we understand that it's due to vitamin B12 deficiency. Now you have this injection with you. Remember, I'm not promoting any product here. I'm not being paid by any of these companies. Only reason I'm showing you this because you need to have some brand names handy. When I started working as consultant, one of the major problems I faced was, I couldn't remember, like when I was in my college, I would write generic names. Now when suddenly I become consultant, it was difficult for me to remember the brand names. And I don't have in-house pharmacy with me, so I have to write those brands which are available in major medical shops like MedPlus, Apollo, etc. So at least know at least 1 to 2 brand names. That is the only reason I'm actually discussing this here. Okay, now you have to give the patient vitamin B12 injection. How will you give it? We need cyanocobalamin 1000 microgram. How much does it have? Okay, it has 1000 microgram. 3 ml in 1000 microgram. So my prescription will be like injection optineuron, 3 ml IM. Now let's first follow UK protocol, right? What does it say? It will say first 6 doses should be given at interval of 3 to 7 days. After that, shift the patient to monthly, like once in a month or once in 3 months. Today's date is 19th July, okay? Let's take gap of 4 days. First dose will be on 19/7. Second dose 20, 21, 22, 23/7. Third dose 24, 25, 26, 27/7. Fourth dose 28, 29, 30, 31/7. Fifth dose 1, 2, 3, 4. 4th August is holiday, Sunday, so I'll shift it to 5th. Then 6th dose 6, 7, 8, 9, 9th August. This is how you will write your prescription. So whenever your nurse sees it, you shall be able to understand, okay, first dose should be given on this day, second in this day, and whenever she or he gives it, like they can tick it like this. After this, you will shift the patient to monthly dose, once in a month. Now, what was the other important thing that I said? It was you should always give cobalamin along with folate. Now, let's check this vial. Does it contain folate, thiamine, pyridoxine, cyanocobalamin? Okay. Therefore, you will have to give tablet folic acid 5 mg 100. This is how you will treat the patient. Now same patient but a different product. This is actually Vitcofol. First was optineuron. Now I am discussing about Vitcofol. Okay, now let's try with US protocol. What does US protocol say? First 1 to 2 weeks you will give it alternate day. Then you will give 1 injection per week. Then you will shift to 1 injection per month indefinitely. So your prescription will be like, how much does each ml? So let's see, each ml contains cyanocobalamin 500 microgram. So you will have to give the patient 2 ml. This will be injection Vitcofol 2 ml IM. This is 10 ml, so you can use 5 doses here on alternate days. First dose 19/7. Second dose you will go on alternate day, so 21/7. Third dose 21, 22, 23, 7. Fourth dose, 25th July. Fifth dose, 27, 7. Now 5 doses are done. This bottle is over. Now 6th, 7th, 8th, 9th. 6th to 9th dose will be weekly. So rather than telling them weekly, you can just try it maybe every Monday. It will be easy for patients to remember. Every Monday I have to get this injection. After that, shift it to monthly dose. Okay, this is how you follow the second protocol. Now, does it contain folic acid? Yes, it contains folic acid. So, folic acid additional supplementation is not needed. That's it from my side. I hope you understood that with case scenarios, we should be able to prescribe it better. That's it from my side. Thanks a lot. Have a great monsoon.